Thank you, Sujit. Your last slide is very informative. Just to start with, we are talking about the toric IOL nature, but the point is it absolutely necessary to advise toric IOL in case of moderate regular astigmatism of less than 1.5 diopter during phaco? What we want to achieve, because with the low astigmatism usually does not affect our vision and requires no treatment. The level of astigmatism more than 0.75 diopter causes significant visual distortion and reduce uncorrected visual acuity. So our aim should be reduce the astigmatism to 0.5 diopter cylinder for ensuring good post-operative uncorrected visual acuity and high patient satisfaction after cataract surgery. Now, what is the volume of astigmatism? Actually, prevalence of astigmatism is almost 70% among the patient with cataract. But this huge number is huge. But unfortunately, most of them have less than 1 diopter of astigmatism. And even in those cases, only this 85% of astigmatism needs attention and correction if possible. Now, in this session, we will only concentrate with the regular astigmatism, not with the irregular astigmatism. The regular astigmatism, where the two main meridians of astigmatism are symmetrical and lies 90 degrees apart, not the irregular astigmatism, which are not, the two meridians are not 90 degrees apart. Now, the total astigmatism is generally the corneal astigmatism and the lenticular astigmatism, as generally we say. After removal of the lens, we have to correct only the corneal astigmatism along with the spherical error. So the corneal astigmatism is the anterior corneal astigmatism plus the posterior corneal astigmatism. So after calculating the total corneal astigmatism, orientation of the steep meridian of the cornea is decided. Now the question is how to deal with the total corneal astigmatism of less than 1.5 diopter cylinder. Astigmatism less than 0.1 diopter cylinder hardly makes any post-operative difference in outcome. Astigmatism more than 0.5 diopter cylinder, we have incisional refractive surgery, including the clear corneal incision, opposite clear corneal incision, and LRI. Now, Dr. Sujit has elaborated the incisional refractive surgery very much. Just I want to give an example. Just in this diagram, just see the first picture in which the before corneal surgery, we have the astigmatism of 2 diopters with the rule meridian. That is, at 90 degree it is 845 and in the 180 degree is 43. And if we put the corneal incision at the steep meridian axis is 90 degree, and there is a flattening of the 90 degree, and the resultant steepening of the 180 degree. The spherical equivalent is the same. So there is no change of this is anticipated if the IOL power is required. But what change we get from the coupling effect? The both meridians, that is at 90 degree and 180 degree, both have come to the 44 and 44. Thus we have corrected the 2 diopters of astigmatism only with the coupling effect. Now, we have already discussed by the Dr. Sujit Mishra already discussed about these points, but just to enumerate, the small incision less than 2.5 millimeter has only the local flattening effect. Most temporal clear corneal incision of 2.6 to 3 meter causes 0.5 to 0.75 diopter of flattening of the meridian. And what is the role of SIA? It is already been elaborated by Dr. Sujit. Just to enumerate that putting the primary incision on the steep meridian result in the correction of only a part of the total astigmatism, which is the amount of astigmatism of SIA. Thus we take the help of SIA to correct some part of the astigmatism. SIA matters more and more, especially when the astigmatism is less than 1.5 diopter. There is a nomogram where the difference between K and K2 and the size of opposite clear corneal incision. Here it can be clearly seen that if it is less than 1.75 diopter, there is no need to give the OCCI. Only the clear corneal incision at the steep meridian is sufficient. Thus, we are able to correct the astigmatism up to 1.25 diopter by this nomogram. By understanding the refractive effect of the OCCI, surgeons are able to make this procedure more predictable. It is likely to reduce the patient's spectacle independence and provide high visual satisfaction. For the patient with preoperative astigmatism 2 diopter and above, the residual postoperative astigmatism, even after applying the OCCI, is not sufficient to get the acceptable astigmatism. But for the poor patient, it is still a boon, as it does correct as it is done without additional cost, and it reduces the astigmatism to much extent. What is the choice of astigmatism for the surgical correction? Up to the astigmatism of 0.75, we can use the clear corneal incision at the steep meridian. The resulting SI will correct the astigmatism. For the astigmatism error between the 0.75 to 1.5 diopter, with the rule astigmatism, here along with the clear corneal incision, we add the opposite clear corneal incision. Here is small clips of clear corneal incision. The patient just operated 3 days back. It is not operating हो रहा है जी, क्या किए हुए हो तुम लोग, कहाँ हो रहा है, कुछ नहीं हो रहा है. हाँ जी, ये वाला था, ये वाला. हाँ, इसको करिए, इसको स्टॉप करो. हाँ, just after marking the axis, here it is, the patient is preoperatively 1.16 diopter astigmatism is 123 degree. After marking the 123 degree, we apply at the steep meridian, we apply the clear corneal incision first. Then just at opposite end, after inserting some viscous material, we apply opposite clear corneal incision just at the opposite end. This is called opposite clear corneal incision. Thus, adding the opposite clear corneal incision will correct more than 0.75 diopter apical up to 1.5 diopter cylinder. Next, what is the surgical pulse of the astigmatism correction? Younger patient with low ATR, that is even 0.5 diopter cylinder, 180 degree, should be corrected. It should not be ignored, as ATR will increase with age, because with age ATR will increase. Thus, under limited resources during phaco, toric IOL is not absolutely necessary in case of moderate regular astigmatism of less than 1.5 diopter cylinder, though in case of astigmatism more than +1 diopter, especially an ATR with younger group, as the ATR will increase with age, toric IOL is preferred. Among 85% of patients with cataract having more than 0.5 diopter cylinder need attention and correction if possible, of which the 60% of cataract with less than 1.5 diopter cylinder can be dealt with the clear corneal incisional surgery. The rest 24% of all cataract patients are suitable for the toric IOL. Then question is it absolutely necessary for to advise toric IOL in case of moderate regular astigmatism of less than 1.5 diopter cylinder during phaco? Answer is no. Clear corneal incision and opposite clear corneal incision is sufficient for the job. So take home message is, before starting the cataract operation, evaluate the astigmatism of the patient. If the regular astigmatism is less than 1.5 diopter cylinder, we can use clear corneal incision and opposite clear corneal incision to correct the astigmatism to get the post-operative uncorrected visual acuity and the high patient satisfaction after cataract surgery. Thank you for your kind attention.